I've been sort of tasked with, I think, giving a pragmatic, perhaps a slightly more pragmatic perspective. By way of background, I am the clinical lead at East Sussex Healthcare Trusts for Elderly Care. I'm involved with that as clinical lead in Sussex Together, but also have done guideline work with NICE. And therefore, I'm very used to critical evaluation of data. And what I'll present today is a little bit of data, and I'll clarify that in just a second. My idea of the future is something around a concept of a virtual ward round from a hospital consultant perspective. And it's a question of how one reaches that to me as part of this. It's interesting when you come to do a talk like this and you think, I know a bit about the data, but I'll go back and have a look at it in more detail. And this emerges from work I've done before with NICE. I don't know if all of you know this quote, but the deeper you look, the more evidence you can find to justify any position you wish to take. And of course this applies to me as well, so I will try and be objective. Okay, you should all know what this is, but let's take a line here. Basically, there are about 300,000 people in 2007 who are age 61. This is the post-mortal population burst that occurred. Bear in mind now, we're 2012, so these people are just reaching retirement age. 10,000 people a day in the US reach the retirement age. 2,000 a day in the UK reach retirement age. And there's going to be a little burst here in the next couple of years, which might just be relevant to the budget. So perhaps it's interesting when you look at these things, and then it will calm down, but then there's the tsunami, this extraordinary increase in population. Now the numbers are increasing, the whole baby boomer thing. This is, if you remember two things about my talk, it's that and this slide. This is ONS data, Office for National Statistics. Here is years, here is life expectancy for women and men typically. That's a Roman centurion, lived to about 29. And basically, a chimney sweep in Victorian times did no better. And then there's this extraordinary inflection in about the 1950s, which those of you who are public health minded need to realise it predates any of the clever medicine we practice now. It's predominantly cardiovascular disease, and it may well be antibiotics, which is very interesting. But notwithstanding, here's when the NHS was invented. And therefore, there is a fitness for purpose issue about the current model because it cannot have anticipated that kind of issue. And I think if you paint that context, then it is inevitable that we need creative solutions. And so healthcare will have to get smarter. To me, that is just utterly self-evident, but bears stating, because for the same reason, universal healthcare is fundamentally unaffordable. So is universal social care, so are pensions. And that's why we're at the foothills of all of these skirmishes, which will increase over the next 10 to 15 years. And we have to face up to that. So what is smarter? To me, this is just me preparing the talk over the weekend, but I'm trying to hone it down to how I think you deliver the maximum with, not the minimum, but the most efficient, aligning care with maximum need, optimizing care when that need is identified, maintaining health. And I've put prevention, and I put it in brackets because to some degree prevention is in part the problem because you create an elderly cohort who still reach disease at the end, and we still consume a lot of resource at the end stages of healthcare. So there is a sort of circular loop in that. So when I was trying to think through this, I was thinking, well, so smarter, it seems to me that one of the national messages is smarter is telehealth. And that's great, but it begs the question, what is telehealth? And so, like any tech-savvy person, I went on Google. And here's what I found. Lots of pictures of boxes and lines. Not many people in that one. And there's the NHS one. And I must say that I kind of felt cluttered with information. John Cleland is a man who advises a couple of companies on telehealth, possibly some of those here, who is a professor of cardiology in Hull, is part of the Cochrane group, and I will come to a Cochrane analysis performed by his group. These are the national evidence-based analyses. And here is an editorial in the European Journal of Heart Failure from 2009, reviewing studies to that time on telecare, telehealth. A major problem with the current trials is that the needs of the patients in the control group may have already been met by expensive interventions. I will return to this. There is an emerging issue that I will come back to about if you have good care to start with, your win with telehealth may be diminished, at least in heart failure. Come back to that. Their conclusion, the value of telemonitoring is not yet conclusively proved. Larger trials with better technologies which address patient populations with unmet needs are required. These things are called forest plots. Look at the top one. This is now the 2011 Cochrane meta-analysis, about as good as it gets for a review of all the existing information worldwide to support the evidence base for telecare. Now, in the top we have structured telephone support. So the authors, which included John Cleland and his group again, looked at studies that relied solely upon telephone contact, defined as structured telephone support, or others that measured physiological variables, blood pressure, heart rate, pulse oximetry, oxygen saturations, and so on, weight, and then clustered their results accordingly. Would point out total of 3,000 patients here, total of 1,400 patients here in this data. So this is the world evidence to date in 2009. Is not that great. Multiple small studies, as you can see by the numbers included in the studies here. This is the same study from 2009. This is structured telephone support, and in this case, hospitalization. Again, struggling to find an effect with structured telephone support, and again, a lesser, well, marginally significant reduction in hospitalization with telemonitoring. So the suggestion being in this meta-analysis, the Cochrane meta-analysis, published in 2011, but with studies up to 2009, possible mortality benefit, but not a lot else. Okay, so now, I'll bring it up. This is what the authors concluded. And this is very, very important, this whole meta-analysis. Number one, there was evidence of publication bias. What that means is some small studies may well have not been included because the investigator does not offer their results for publication, or because the paper was rejected. The reason they say that is statistical analysis does demonstrate some degree of heterogeneity, it's referred to, which means a skewing of the way the results are presented from what you would expect, suggesting that there should be more equivocal studies, so that authors themselves suggest evidence of publication bias. The second fundamental thing to consider in this meta-analysis is this. It intentionally excluded other methods of follow-up and management that have been reported to improve outcomes, such as nurse-led or specialist heart failure clinics or home visits. So in picking the studies, they looked specifically for those in which usual care was in effect not much, forgive me, other than general practice and an ad hoc approach. There wasn't a structured clinic, there wasn't a structured community nurse service. Now these studies are often conducted in parts of Europe that tend not to have an advanced primary care structure like the UK, or in America. So we do need to see that context in this. The authors concluded telemedicine might be more efficient and less expensive an option where the quality of usual care may not be as developed. Going through this, what came out of this for me was, firstly, at a value release, and I think in the Kent, I looked at the Kent report, there was the involvement of patients in care and the feeling of belonging for a patient, I personally think is an extraordinarily important factor in all of this that's sometimes difficult to see. I'm very lucky, I'm based at the Conquest Hospital, and we have a hospital nurse, we currently have a sort of discharge coordinating nurse and 2 community nurses. And we've had that set up, well, the community nurses now for 7 years, we've got them through the British Heart Foundation. And we work as a single team, and we meet weekly, and I get phoned and emailed by the nurses in the community, and I'm very happy to take on anything that comes up in a patient who probably has heart failure. And one of the recurrent themes is the sense the nurses get back that perhaps 50% plus of their worth is the fact that they are an ongoing interest in the patient. And I think there's something very interesting about telehealth in this. I think there is something, and I've read it in other articles, this notion of the patient not feeling left or abandoned. Not necessarily owning their care, but this idea of there being an ongoing interest. And I think the other thing, I've mentioned measurement here, I think there is a temptation, because we can measure weight and pulse and blood pressure and things like that, to measure them. And then the information gets fed back and we can do something with it. And I have to say, for heart failure, I'm not sure whether the cart and the horse are joined up there. And I think this requires thought. And what I'm coming down to is the exchange of useful information. I think, and we've heard don't rush into this, we've heard start sensibly. For me, particularly for heart failure, it is where is the most likely to be the most useful gain in this. Is it contact? Is it measurement? What is that population? I don't think we clearly know, but I've hinted in the talk at what I think it might be. Let me try and suggest things. There are 2 points I want to make here. Well, at least 2. One is to NHS Sussex. Hands up the accountable officers from NHS Sussex. Okay, all right. One of the things that came out of the elderly care work stream is, and boy do we sit, I also am the regional lead for the Enhancing Quality Heart Failure programme, the hospital side of it. There is an ongoing chasm of communication between primary and secondary care. And I think we can measure patients widgetry till the cows come home and go back again. And if we haven't dealt with that chasm, we will not release the full potential of systems, particularly in the transformation that's going on. I really think that. We are very fortunate where I work. We've often been asked, how come we managed to get on in Hastings quite so well? The community nurses access the hospital information system. They can access the echoes, they can access all of the information they need, all of the correspondence is done there, my clinic letters are on there, so there is nothing they do not know immediately. And that is probably our greatest secret weapon. That is virtually unique in the South Coast. And to try and think about integrating care in any useful sense, to my mind, without doing that first, maybe missing a trick, personal view. Based on my own experience, though, in heart failure, that communication isn't just between primary and secondary, it's between health and social care. Because in the discussions we're having, yet another hat I wear is the community redesign group going on at East Sussex Healthcare Trust, which in fact aligns with the elderly care work stream from Sussex Together, which is looking at this whole idea of neighbourhood care teams, which I think is essential given the demography. But health and social care need to talk to each other just as effectively, and primary and secondary health care need to talk to each other. And I really do think if we rush at telehealth without sorting that bit out at the same time, I'm troubled. So that's that message. Where's Amanda? She knew I was going to say, so she's seen my slides or something. The second is the direct measurement of physiological variables. Measuring things. I've mentioned this before. To me, the maximum utility for measuring stuff is going to require a conversation about predicting where that's likely to be. And I think it is this idea of knowing, I think the place to pilot is in those post-discharge. The recurrent admitted patient, the recurrent admissions in whom there is a high risk of further admission for whatever reason. Facilitating some way of having a much more proactive care for them that isn't just about twice weekly visits from a nurse, so that you're supplanting something that we may be trying to do now in a way that liberates the nursing time and yet facilitates the care. And I think we've been talking about this locally, I think that's one area. The other is displacing routine work, such as one of the things in heart failure is you often have medicines that need recurrent increments. And one area would be, I'm overrunning on time, I'm very nearly finished, one area would be about whether you could supplant the routine monitoring of these people. So I think these are areas that we would be very happy to become involved in. I haven't talked, which is this whole issue of risk stratification, and I know we'll come to that, and I think it is a sine qua non of this being effective. I haven't talked directly about the support and involvement of the patient, but I've alluded to how that can liberate benefit, but I don't think in heart failure there's enough to go on. That's all I wanted to say. I'm very grateful for your time and for the invitation to talk. Thank you.
Thank you.